So we're going to see now the types of position flaps. We will see in these pedicle flaps, which are laterally positioned flaps. We will see apically positioned flap. We will see coronally positioned flap. So the first one, the pedicle flap, which is a laterally positioned flap, a positioned full thickness flap performed to correct defects in morphology, position, or amount of attached gingiva. It is usually a full thickness flap that is attached at its base with its free and adjacent to the defect in the recipient side. Again, it's free and adjacent to the defect. The defect is covered by stretching the flap laterally until the free end comes over it. The indications. It is indicated in areas where narrow gingival recession is adjacent to a wide band of attached gingiva that can be used as a donor site, used to correct or prevent recession by providing root coverage, creating a wider band of gingiva, and in the absence of recession, to widen the zone of gingiva. The pedicle flap or laterally positioned flap is positioned and repositioned flaps are really pedicle flaps that are all physically attached at their apical base by a pedicle or of lining mucosa and an intact blood supply. Important factors to evaluate before performing a laterally positioned flap is the presence of bone on the facial surface of the donor tooth, gingiva thickness and width of the attached gingiva at donor site. The double papilla flap is a variation of the laterally positioned flap that uses the same principles, except the gingiva between the teeth on either side are placed over the exposed root. Again, double papilla flap is a variation of the laterally positioned flap that uses the same principles, except the gingiva between the teeth on either side are placed over the exposed root. So that was all part of the pedicle flap. Now, an apically positioned flap is a second point. And an apically positioned flap is a full thickness mucoperiosteal flap with a relatively high degree of predictability that is the workhorse of periodontal surgery therapy. This flap's objective is to surgically eliminate deep pockets by positioning the flap apically while retaining the attached gingiva. Most commonly used in conjunction with osseous surgery as surgical access is obtained for osseous surgery, treatment of infrabony pockets, and root planning. It is indicated in moderate to deep pockets, furcation in involved teeth, and crown lengthening. Contradictions. When patients are at risk for root caries, as excessive root surfaces are often exposed after performing an apically positioned flap, and where tooth exposure would be anesthetic. In the course of flap surgery, after gaining access to underlying osseous tissue and performing the required therapy, the apically positioned flap is sutured to a place at a more apical level, exposing the alveolar margin. When this is done, additional attached gingiva granulates from the periodontal ligament and covers the barely exposed bone. This additional tissue joins the apically positioned attached gingiva to form a broader zone of gingiva. Note, on the palatal surface of maxillary molars, you need to trim the flap margin to proper length during the procedure. And the third flap. Coronally positioned flap is a full thickness mucobursal flap almost exclusively used to restore gingival height in the zone of attached gingiva other over isolated areas of gingival recession. There is no necrotic slough of positioned flaps because positioned flaps carry their vascular supply with them. In a free gingival graft, healing involves revascularization of the graft. The graft's top layers are revascularized last, thus the epithelium dies off, degenerates, and produces a necrotic slough. Okay, so that was it about flaps. And there's a lot more material about flaps, but we need to get going. So, extrusion of a canine. There's a question that says, in an extrusion of a canine, what flap technique is used? All of them will be used except one. Which one? And envelope flap, semilunar flap, or apically positioned flap. This is obviously apically positioned flap because the canine is extruded. So there's no need to move the flap apically. Next question. After flap surgery, how does repair occur? Answers: periodontal ligament moves occlusally, apically, and laterally. Flaps: partial thickness or mucosal flap, only epi and connective tissue. Next, full thickness includes periosteum. In full thickness, you'll find horizontal flaps, horizontal incisions in full thickness. All three together allow for visualization of a alveolar bone. Internal bevel incision, cervical incision, and interdental excision. All these are horizontal incisions. So the internal bevel incision is 0.5 to 1 millimeter from FGM flap gingival margin. It's an apically displaced flap. 1 to 2 millimeters from flap gingival margin. That's a modified Whitman flap, not reflect beyond mucogingival junction. Okay, in a modified Whitman flap, do not reflect beyond mucogingival junction. And a coronal to base of pocket on displaced flap or reverse bevel incision. Now, in cervical incision, the base of pocket to crest of alveolar bone conserves papilla. Again, clavicular incision, base of pocket to crest of alveolar bone conserves papilla. 1 plus 2 creates a collar of tissue around the teeth. And the interdental incision separates the collar of gingiva from tooth. Cover the site with periodontal pack. Don't enhance healing rate. Covering the site with periodontal pack does not enhance healing rate. The periodontal pack contains zinc oxide and some with antibiotics and give chlorhexidine 2 times a day for 1 to 2 weeks. That's all on flaps. Next question about flap. What is a disadvantage of partial thickness flap? Is it visibility or access? Okay, we'll stop there. I'll continue later because I'm sleepy and need to go to bed.